trauma and sports imaging, as well as soft tissue and bone sarcoma diagnosis. He is a competent musculoskeletal ultrasound and interventionalist, including MR arthrography and CT guided biopsies. Sir is an enthusiastic teacher involved in training radiologists in the UAE and abroad, and is a staunch advocate of fostering collaborations with clinicians to help continuously improve the delivery of patient centered healthcare. I think the last line sums up how good a clinical radiologist he is. And I would like to extend this heartfelt thanks to Sir because he accepted the invite on a last minute. In fact, I just messaged him yesterday and he agreed to do this wonderful session with us. We are really thankful, and I'm sure we'll invite you on this platform again with more time frame with another interesting topic as well. So thank you so much. All over to you. To the participants, if you have any queries, put them in the Q&A section, and for any technical issues, post them in the chat box, please. Thank you, sir.
Great. Okay. Thank you, Dr. Mehta. Yeah, it's an honor, and thank you for giving me the opportunity. So the lecture I'm going to kind of give for the next hour or so is, I've given this at my own hospital that a year back, but I think there are a few valid points which I would like to share with my colleagues who are attending this webinar. So the title is Clinical Approach to Acute Musculoskeletal Imaging, and the objectives will be that we need to realize the importance of pertinent clinical information when interpreting the radiological studies, recognize the use of different imaging modalities for acute MSK imaging, and understand the interplay. We might have to resort to kind of other imaging if you're looking at MR or ultrasound, things like that. So just before, at the very outset, I'll say there'll be a lot of images because as one of my friends says, radiology, the language of radiology is images, right? So you'll be bombarded with images. I'm not going to reinvent the wheel, but I'll just share my experience, and hopefully there'll be a few learning points which you'll find useful. Right. Okay. So that's the talk. Right. Okay. So let's go. So these are familiar images there. I mean, that's Leonardo da Vinci. That's his human, and that was his drawing. So the basic thing about radiology and musculoskeletal radiology, I think, is that anatomy is key. We all have to be well versed with anatomy, the intricate details of it, the range of normal variation on imaging, because that will help us pinch the diagnosis, right? So anatomy, there is no surrogate for that. It improves as we kind of go through our career. It builds with experience, but we have to have a sound foundation. Okay. So just to reiterate that, I mean, these X-rays, I'm sure most of you can pick it up. The arrowhead is there. So you've got these tiny fleck of bones at the just at the volar aspect of the MCP joints, the PAP joints of these fingers. And as you would know, this is volar plate injury, right? This is one of the common missed injury on a hand trauma hyperextension injury, but it's very significant. So if we know that there is a fibrocartilage thickening of the capsule on the volar aspect, which is very important for the stability of MCP and PAP joints, then we can pick it up, and then we can avoid. We can prevent long-term comorbidity, because sometimes it's us who highlight these injuries, and then the clinician can act upon it. Okay, and then clinician. I mean, I work in a tertiary care hospital, so as the last line in my kind of intro kind of was quite emphatic about it. But it's very important for us as radiologists to build that relationship, and the clinician. The door should always be open, right? I know, I mean, it might be a bit tricky to do it when you're working in an imaging center, but try to build that relationship, because you will have few frequent kind of clinician who will be referring patients to you. So it's important to have this two-way traffic, because nobody is perfect. Right? We need to kind of help each other build experience and then learn from our mistakes and get the feedback from the clinician, because that is very important for our kind of continuous professional development. Okay. So why do I say that, right? I mean, I'm going to reiterate that with a few cases. This is a patient who was, as it says, a postpartum severe hip pain. She just delivered a baby and she was in severe pain, can't wait there. And they were thinking she's got acute disc prolapse rather than a fracture. We did this MR. You can see the postpartum uterus there. And then you can see marrow edema on both sides, and the proximal femoral head are going up to the neck. Okay? And so most of the time when we image in acute MSK, I mean, particularly regarding the MR, we look for bone marrow edema, right? But for us, it's important to identify where it is and then why it is. That's where our kind of clinical acumen or experience comes into play. And these are the axial images, as you can see. I mean, she's got a displaced intracapsular fracture on the left side, which was the worst kind of symptomatic side, but she also has got subchondral, got extensive edema on the other side as well. And when you look at the coronal T1, you can see that there is a subchondral insufficiency fracture. So this is an unusual kind of unusual finding, unexpected finding, let's put it that way. But the other thing is, if you look, the marrow edema is quite disproportionate. I mean, you might say that there is a fracture, that's why there is edema, but look at the edema on the other side. And when we talked to the clinician, they said the patient had pain for a few months before delivery. So these are typical kind of findings of transient osteoporosis of pregnancy complicated with fractures. And why do I say that? I mean, this is another patient. If you see, I mean, this is like MR, you can see a similar kind of pattern of marrow edema, extensive diffuse involvement of the head and neck. Okay? And if you look at the X-ray, I know it takes, I don't know, it's projecting, but it's a good habit of comparing one side with the other. If you see here, you can see the trabeculae nicely, but this side looks a bit washed out in a young patient, in a childbearing female. If you see this, and she's got hip pain, you always have to think, could it be transient osteoporosis? This patient was, when we did the MR, it was there, then it got better, and then about 18 months later, if you see, it's on the other side, and she was again pregnant. Okay. So these are fleeting kind of things that come and go. I mean, it's described in pregnancy, but can happen in young men as well. So whenever you see this kind of extensive pattern of marrow edema, always think about transient osteoporosis. Okay. So it was unexpected, but it has to be communicated to the clinician, and then they fixed one side, and the other side they fixed as well prophylactically. Okay, another one, 7-year-old boy who presented with some kind of pain, a bit of limp occasionally, but there was a history of some penetrating injury, and they were questioning whether there is a foreign body. So this is ultrasound. I'm sure most of you will be doing ultrasound. So this is from the plantar aspect. That's the plantar fascia there, right? And there is a hypoechoic collection over the plantar aspect in the subcutaneous fat, but there's something else going in the deep tissue as well. And then when we look further up proximally, I saw this hyperechoic foreign body. It was like a date palm frond. And then you can see there's an abscess around it, increased hyperemia, but it went quite further up. It was like a tract which was going from the forefoot into the midfoot up to the hindfoot. So then we raised that this patient could have osteomyelitis of the calcaneum. And lo and behold, when we did the MR, you can see there's a tract which is enhancing. There is enhancing marrow edema in the calcaneum. And the other sign, which I'm going to show you a few times in this talk, is on a plain it's quite pathognomonic of an abscess, which we call a penumbra sign, whether it's in the brain or in the muscles or in the bone for that matter. You have to give adequate kind of importance to that. So this was, again, it was unexpected. So we communicated to the clinician, we did the MR, and next day he went to theater and they took it out. Obviously, he needed antibiotics for 6 weeks, and he did well afterwards. So again, it's important that when you see something unexpected, just think a bit outside the box, or what can go wrong. And then if you are going that way, then give it to the clinician. Okay, this was the radiologist. I mean, this was myself, I call the clinician. But there was another story, another patient, 39-year-old. You can see that there is definite abnormality in the midfoot, particularly medially, medial cuneiform. It looks irregular, some sclerosis there. There's some lucency there, and also cuneiform arthropathy. 39-year-old, not diabetic. We did an MR because they were thinking he might have some trauma or there was osteomyelitis. And as you can see on these selected images, there is a sinus there. There's a sinus that goes down, which communicates with a cavity in the medial cuneiform. And then there is something inside. On a T1, it looks a bit sclerosed. On the stud, it's a bit hyperintense. And on a T2, it's just there. Okay. We thought it's a sigistrum. I mean, it's like a discharging sinus, chronic osteomyelitis with an abscess cavity with some central kind of necrotic bone. Okay. We look at on the post-contrast, you can see there is kind of enhancement around it, but that thing itself is not enhancing. It's probably dead bone. But when you do CT, It looks a bit dense, but it's not as dense as a sequestrum would be. Sequestrum are usually dead, sclerotic kind of dead bone. So it looks like something which is a bit dense, less dense than the bones. What is it? Well, we still call it acute chronic osteomyelitis with probably some dead material in it. And then the clinician came back to me and they found this. They found a rubber foreign body because the patient had some injury. He was wearing some flip-flop. It went in a few years back, and lo and behold. So again, so that two-way traffic is very important to kind of build that experience so that when you are dealing with unusual things, you are a bit more confident. Okay. So that's what we call clinical radiological approach, right? We are radiologists, but we're clinical radiologists, and we need to have that communication with the clinicians. Okay. And we also have to have a clinical thought process. Okay. So for that, let me take an example of few cases of heel pain, right? Okay. Heel pain is quite a common condition that comes to our MSK clinic. I don't know how about in India and Pakistan, but in here, I see more heel pain patients than probably I was seeing in UK. And most of the time, the question is, has the patient got plantar fasciitis? If you see that with a linear probe, when you've got normal fibrillar architecture on the right side with the thickness of about 3.64 millimeter is the cutoff we use. It can be less or more depending on where you work. But obviously, this is definitely much more, all right? Okay, and sometimes it is associated with a calcaneal enthesophyte or a plantar spur. So this is plantar fasciitis. But sometimes what we find is that the patient has got severe pain, but the plantar fascia is normal thickness. So then we can't exclude active enthesitis, because enthesitis is where the fibrocartilage is at the tendon or ligament insertion. People with psoriatic arthropathy or reactive arthritis or seronegative arthropathy, they can have active enthesitis. And in those patients, obviously MR will take the edge, because MR can pick things up much earlier before the structure itself thickens. So this is something we encounter more often, that you got either plantar fasciitis on ultrasound or active enthesitis. So this is the common grumbling on kind of chronic, acute and chronic kind of symptoms. So this is the common condition that we encounter. But what about if somebody presents with severe heel pain? Okay. So then you have to think about if the patient had some pain and suddenly it got worse. So certain things are few in MSK, right? Okay. You always have to think about, if I take you through, this is one side, this is the other side, you can see that there is edema of the central band of the plantar fascia on both sides, but on this side there is some interruption. See, and when you look at the short axis view, there is focal fluid signal there. So this patient had acute plantar fascial rupture. So when somebody presents with severe kind of symptoms, you always have to think about, could there be a rupture? So tendon rupture, ligament rupture, injury, you have to think about trauma in the acute setting. Okay. What about this patient then? This is a patient who had severe bilateral hip pain, Asian lady living in UK, and that you're not able to wait. But again, the question was, you got plantar fasciitis. So we did the MR. I mean, I don't know whether anybody of you can look at the X-ray and find something. Probably a bit of osteopenia there, but nothing major. No plantar calcaneal spur. But lo and behold, when you do the MR, these are two, like both sides were done. So I'm showing you just selected sagittal stir images, and you can see there is a band-like marrow edema and there is a fracture line as well. So she's got insufficiency fractures. Her vitamin D was low, just probably related to that. So always think about when there is severe pain, patient is not able to wait there, you always have to think about fractures. People can live with fractures with normal X-rays, okay? Because obviously, if you go back now, you can see a bit of sclerotic band there, but I think it'll be tricky if you keep on calling everybody like this as fractured, then I think we'll get probably too many MRs. But again, it's the clinician, I mean, who needs to raise that. If the patient got bony tenderness, they're not able to wait there, then you have to think about insufficiency fractures. Okay. Right. Well, this is easy. I think we are used to these X-rays. I think in our part of the world and in the Middle East as well. I mean, poorly controlled diabetics with poor foot hygiene, and you can have an ulcer, and then you can see that previous X-ray there was some kind of ulcer there with a bit of gas, but then a few months later you can see there is destruction. So it's like active osteomyelitis, which obviously, I mean, you would say, why we need an MR? But I think MR is important for the clinician, for the surgeon to go in and to delineate whether they have to go in. Is there a collection to drain? Is there a necrotic bone? Things like that. So this area, as you can see, this involves the plantar fascial attachment, and there is a destruction of the plantar aspect of the calcaneum. This is acute osteomyelitis. Okay. What about this? I don't have an X-ray for this child. He's a child who was unwell, and as you can see on these set of images. The last two images are post-contrast, but let's just delve on the non-contrast one. So the stir, the calcaneum is lighting like a light bulb, but there is a fluid-containing cavity in the back. And then again, T1, you can see the edema, and then you can see the penumbra sign. And this is the T2 weighted image. So this was like a Brodie's abscess. Okay, again, penumbra sign. So, I mean, these things, you always have, so injury and then infection. Okay. And then obviously, I mean, rarely people can present with these things as well. So this was like, you can see there's a lesion there. I mean, it's not intraosseous lipoma, which is usually hair. It's more like an infiltrative, destructive process, probably going into the tuberosity. And when you do the MR, you can see there is a T1 iso-intense infiltrative lesion, which extends beyond the confines of the bone, involves the Achilles tendon insertion. When you look at the T2, you have a typical cauliflower-like T2 hyperintense chondral kind of appearance. This was a high-grade chondrosarcoma. So again, but the history would be swelling and lump, right? But these people, I mean, these cases can end up on your list in the acute setting as well. So to summarize, I mean, when I look, when the history is painful limb or pain or things like that, so my MSK kind of starts with this, that you got injury. I've shown you injury cases, infection, okay, yes, with the ulcer or without ulcer, with a foreign body or in a child. Inflammation, people can present with the first presentation of seroactive inflammatory arthropathy or post-UTI or like a reactive kind of arthritis. So always think about that. Okay, infarction, that's another thing which can present. I'm going to show you a few cases of. Okay? And obviously infiltration, whether it's primary in kind of young population, 40 or less, or secondary when people start kind of presenting with widespread metastatic disease. All right, okay. So that was, let's just go back. All right, so just keep that in mind. Let's just kind of see if I can hammer these points again by just moving into the upper limb now. So again, acute shoulder pain injury. Obviously, I'm just showing you the medley of different kind of fractures. Undisplaced greater tuberosity fracture, fracture dislocation 3-part. This is again a fracture dislocation. And then this one is like a decapitated kind of thing. So you'll be definitely worried about the vascularity of this, and it would need kind of follow-up surveillance to see if there's any AVN of the humeral head. Okay. But what about this? If I tell you this is a 70-year-old and this is shoulder pain, this came from orthopedic surgeon, and if you look, I mean, the bone doesn't look right. The fracture is not a typical kind of fracture. There's a bit of like a band-like lucency there. But for the clever eyes, you can see a bit of periosteal reaction there. It's quite swollen, whether it's a hematoma or it's something else. And then the patient had history of renal cell cancer. He did a nephrectomy a few months back. So pathological fracture can also present. So whenever you see a fracture, I think as a radiologist, it looks acute, typical, fair enough. But if there is something iffy, then you have to raise that. Could it be insufficiency? Could it be subacute? Could it be pathological? Okay. Right. But more commonly, when kind of acute shoulder pain is usually by a rotator cuff tendon tear. Right, okay, and usually we resort to ultrasound for that. And on ultrasound, which I'm going to show you figures later on, well, all we are looking for is discontinuity, whether it's bursal surface with articular surface involves the insertion. Ultrasound is usually useful, right? And then obviously, if it's a complete tear, then obviously the deltoid will be sitting on the humerus with no supraspinatus or infraspinatus tendon in between. You can do an MR if the surgeon wants it. Yeah, sometimes this can be the MR. MR might be the starting point, and you can see the supraspinatus tendon has been retracted up to the joint line. This is too far, I think, to be pulled back. It obviously depends on the age of the patient and the functional status, and the surgeon can then decide whether to leave it be or to do a replacement or to repair it. But most commonly, we see these in young people, I think, at the insertion, which can be picked up nicely on MR, but similarly on ultrasound as well. All we are looking for is fluid-filled cleft, discontinuity of the tendon. So cuff tear is much more common. Okay. What about this? I mean, I put the MR, I know, just for the sake of time, I'm just showing you images together. But this one, if you see, I mean, there is this is the right place for calcific tendinitis. But for the clever eye people, you can see it looks like bone, right? It's like a lobulated kind of bone. And if you see, there's a bit of a defect here. Okay. This is called a calcific tendinitis, but on ultrasound, we thought this looks a bit more. And there was a history of a fall. You do an MR and you can see the donor site marrow edema, cortical break there, and the infraspinatus tendon has pulled the fragment back. So emulsion fractures, they can present as as acute shoulder pain. So always think about that. Not everything that looks dense in this space is calcific tendonitis. Okay? But coming to calcific tendonitis, I mean, it's again very common. I don't know about your part of the world, but we see probably every week we see somebody who walks into the clinic with a ghast look, severe pain, can't sleep. And then if X-ray is available, fair enough. If not, then when you scan them, you see this kind of a cloudy kind of density with ghosty kind of shadowing at the back. And occasionally, if you put color on, you can see active tendonitis. But most of the time, what you find is there is acute active kind of bursitis, which gives them the grief. So this is another case. You see, if it was like about a few months back, the calcific deposit was there, hydroxyapatite, and then a few months later, when patient presented with acute thing, you can see it has slipped off. It's lying in the bursa and causing all that florid chemical bursitis, which gives them a lot of grief. So in these patients, usually in the acute setting, we tend to inject them with steroid and local anesthetic, and then a few weeks later, once the acute episode has subsided, we go and needle it, or sometimes we aspirate it as well if it's aspirable. So calcific tendonitis and bursitis, quite common, much more common, I think, than you think. And obviously, it can mimic septic arthritis and things like that. So always think about calcific tendonitis. This is another patient. I mean, I put the delivery 2 months ago. So these are 2 radiographs which are like 6 months apart. I mean, you can see that there is some heterogeneity, a bit of osteopenia in the humeral head. But if you look at the margins of the humerus there, humeral head there, you can see there's a bit of marginal erosion here, marginal erosion here. There's a bit of erosion there as well. And then when you go back, you can see these are teeny bits there. So this patient was known rheumatoid arthritis, which came to my ultrasound list at my previous hospital many years back. And then she was off treatment because she was pregnant. And then after pregnancy, she came with worsening pain. Then on MR, you can see the typical cogwheel appearance, and then you got the pannus there. So think about inflammatory arthropathy as well. Young people can present with arthropathy, like seronegative will usually present with the big effusions, bursitis, things like that. Or you can see sometimes erosions as well. So I mean, it's just a common, but it's an unusual look. Whenever we think about rheumatoid, we think about small joints of the hand and feet. We forget it can present as large joint inflammation and erosions as well. Okay. What about this one? Okay, so I put a severe shoulder pain and unwell. When the patient is unwell, they've got fever or there's comorbidity like they're diabetic and things like that. And you always have to think about infection, obviously, right? And there you go. This is like that appearance of the one I showed you in the heel. Again, extensive marrow edema with that cavity. Okay? And then you see there's effusion, but there's edema that has crossed across. So infection tend to cross the joint. So this probably is complicated with septic arthritis. Okay? What about this one? I mean, X-rays are very useful, but I think it's a good habit that if you're reporting an MR, see if there is any previous X-ray or their previous series of X-rays, even better. So this is a young patient. They were acute on chronic shoulder pain. Okay? So if I put them there, like these are just over about 18 months subsequently. Okay? So now you go back to that, and you can see there is a bit of high density in this young guy who's known sickler. I mean, sometimes that history is not given. Sometimes we are the first one to say that this patient has got some underlying hemoglobinopathy. So always think about that. So this is AVN complicated with infection. Okay. I mean, I think, well, I know this guy because he was presented with some sepsis and all that, but this is like rapid progression. AVN usually doesn't kind of cause this degree of osseous destruction unless it's complicated by infection. Okay. And the patient had, you can see, I mean, the MR, he's got acute infarcts in the femoral shaft as well. Okay. So just delving a bit more on sicklers. I mean, whenever somebody like, okay, what I'll do is I'll put the other X-ray up as well. Again, I'm just trying to get the point across that it's always a good habit to compare it with a previous X-ray. So young patient, she got worsening left hip pain for 6 weeks. If you see 6 weeks back, we've got an X-ray, or about, I think probably 6 months back. The heads look fine, the joint spaces look okay, right? But now if you see, there is like significant loss of joint space over a short period of time, talking about months. You have to think about infection or acute flare-up of an underlying inflammatory arthropathy. Okay. And when we did MR, I mean, you can see there's AVN, yes, but patient has got infection as well with that tracking abscess in the gluteus medius muscle. Okay. So always think about sickle cell disease with avian and infection. Okay, well, I mean, you're all probably aware of these. I mean, we usually see we usually identify these things on X-rays, head-shaped vertebrae and all that, but in the acute setting, you can have these multifocal marrow abnormalities on these stir images, and then sometimes they can be quite extensive. This is not sacroiliitis. I like this image because it looks like patchy, big kind of patches of marrow edema, but the patient has got sickle cell disease. So, and then there's nothing on the other side. So this is like just subacute infarcts. Okay. And similarly, I mean, we think about sickle cell infarction just affecting the marrow, but it can also affect the muscles. I mean, it's probably we don't image them that much. That's why in the acute sickle crisis, we just kind of deal with them. The clinician deal with them, whatever they want to do. Usually, they don't image them unless there is concern for infection. This is a patient who's known sickle cell, and then she has got this extensive edema involving the triceps muscle of her right arm, and then 4 weeks later, that has subsided, but now she's got marrow changes there. So things infarction, you always have to think about infarction in the marrow as well as in the muscle. And that can sometimes, it can take some time to develop. So just that. And then, I mean, again, other thing is if you see that MR appearance and the patient is on end-stage renal failure, diabetic, they can have what we call myonecrosis or necrotizing myositis. Somebody does extensive exercise and then CK is up, things like that. So you always have to think about that. So you see the imaging can mimic each other, but in the right context, you can probably raise the correct diagnosis. Okay, moving on, again, acute and chronic shoulder pain, series of images there. In this image, you can see there is widening of the subacromial space, which tells you whether there's an effusion or is a pseudoparalysis post-trauma. But I always, whenever this is this wide, you always have to think that there is a big effusion or hematemesis. Okay, and then if you look at the bone, that doesn't look right. There is some lucency there, and when we do MR, you see this appearance. So this is, I think most of you have seen it. This is extensive hemocydin deposition in the synovium. This is not primary synovial, tenosynovial giant cell tumor. It's too extensive, and there is big erosions there as well. This is patient with hemophilic arthropathy. So think about sickle cell and hemophilic arthropathy. They can usually present with acute limb or joint pain. Right. Okay. So I'm showing you this case, 28 weeks pregnant lady with severe debilitating shoulder pain. I mean, I still remember this lady. She walked into my clinic and she was crying. She said, I've got so much pain. Can you do something about it? And then I did an ultrasound. I thought there was no cuff tape. There's something else. And then we said, we'll get an MR, which happened there. But before the MR, there was an X-ray. And I'm just putting that MR there just for you to see that on this T2-weight image, you can see the marrow infiltration there, there is like a discrete kind of border with the normal fatty marrow. Okay, but when you look at the X-ray, look at that. So that's what X-ray is useful for. X-ray just gives you that idea how aggressive this process is. I mean, with experience, you'll probably realize that this is too much. This is like permeative destruction, or probably there's no bone left in the medial aspect here. But when you look at the X-ray, you're just like, great, okay, not great, but in a way that, yeah, they just kind of hammers it in that this is very aggressive tumor. So in a young patient pregnant, you think about hormone-sensitive tumors, which can be giant cell tumor or ABC. It doesn't look like ABC though, or it could be something like lymphoma or Ewing. So it was biopsy, then it came back as GCT. So, right. So coming back to that, right, the moral of the talk today is that whenever you're dealing with a painful limb, think about injury, that is the soft tissue or bone, infection, inflammation, infarction of the bone or muscle, or infiltration, which can be primary or secondary plus minus pathological fracture. Okay. So that's the clinical radiological approach. Okay, a few more cases. I think we still got time, so I'm going to carry on. So this is a 30-year-old male football injury. But the history of injury, you're thinking about avulsion fractures, isn't it? And especially in young people or muscle tears for that matter. You can see there is an asymmetric kind of calcific density at the anterior inferior iliac spine, which is the site of the region of the rectus femoris. You do an MR, there is edema there. So this is a avulsion injury, common kind of common area. And then this is like this is not a difficult diagnosis to make. Okay, but so rectus femoris emulsion fracture. What about this patient, right? 35-year-old male, severe hip pain. Again, you're seeing like a calcific density next to the ASIS. There's no history of injury. There is no kind of donor site there. But could it be an old injury? Okay. Or when you do an MR, you can see there is marrow edema there. Okay. There is edema in the muscle, in the tendon as well. Okay. There is probably some interstitial tear going on there. So this is calcific tendonitis, unusual location. We are more kind of used to seeing this in the shoulder, which I have shown you. So this is another case in which the calcifium has gone into the infraspinatus muscle, causing all that inflammatory myositis. Right? So unusual location, but the same pathology. Calcific tendonitis, hydroxyapatite, crystal deposition. What about this one? Wait, I'll just show you. So this patient, this is again young patient. I mean, MR done because he's got hip pain, and you can see there is marrow edema. There is this kind of a irregular fluid, something happening there. Okay, and then 4 weeks prior, there was little bit there. So something rapid has been pestering there. Started there, within 4 weeks, it has got to this, and then this is the CT. You can see there is focal lysis there with endosteal scalloping. 2 weeks later, it has got much more. So, I mean, is it infiltrative tumor? Is it infection? I mean, whenever I'm encountered with this, when there's a rapid progression in the bone, of this degree of marrow and of destruction, this is an aggressive process, very, very aggressive process. So infection is usually much more aggressive than primary bone tumors in a short, talking about the chronology of it. So we biopsied it twice, and then on both occasions, we didn't find any tumor. And they grew some staph pasteurii, which is an unusual zoonotic kind of organism. So, and then you can do gallium scan as well, and you can probably see a little bit of activity there. So you have to think about infection, and sometimes with infection, you have to just kind of sit tight. I mean, obviously, it would need a biopsy, yes, but you have to wait for the culture result to come, and sometimes you have to do follow-up imaging. Either things get worse or things get better. This patient had an MRI about 6 weeks after antibiotic treatment, and all that marrow edema that we saw, it got about like 70% better. So it was responding to treatment. So think about infection. It can present with acute kind of pain. An injury, I'm just showing you a few more cases there. This is like a horse rider. She was kicked. You can see there is a muscle tear, the big hematoma there. Okay. And another patient, you can see a little bit of cortical break there with a big soft tissue hematoma. So that's what a fracture is, that you got a soft tissue injury in which a bone happens to be broken. So always look at the soft tissues. Sometimes the soft tissue injury kind of is much more than the bone injury. And obviously you all are aware of these Sagan fractures, little flex, big effects, okay? And then always look at the lateral x-ray for this like a curvilinear thing. It looks small, but this is the tip of the iceberg, as we know, because x-ray will just pick your cortical bone or subchondral cortical bone. There might be a big cartilage fragment lying related to that. You can see that it's a big 1.5 centimeter kind of fragment there. And then you can see it has come from the weight-bearing portion of the central lateral femoral condyle. So this would need kind of putting back. So sometimes these little flex, big effect. So we as radiologists should be well versed with these. Another few cases there you can see. I mean, it's much bigger than a Sagan fracture. Usually, the location is anterolateral area, but this is a large chunk there. Okay. This is the ITB avulsion fracture. Patient has got some subarachnoid hemorrhage as well. So, right. So, why I'm showing you this X-ray? I mean, if you see, this is again a young guy, about probably 12-year-old. He had a twisting injury. X-ray was reported as normal because there was no lipohemarthrosis at the time. But if you see, there's a bit of triangular fragment here. Could it be normal variant? Is it just the physis which hasn't kind of fused? We did a CT. On the CT again, I mean, it looks like there's a well-defined thing here. It's got a cortical kind of outline here, but it's a bit irregular on the top. Again, it was neither here nor there. And the patient, the clinician was worried that there is much more going on in the knee in this child because he was not kind of weight bearing or not behaving as expected. And then we did an MR, and you can see, lo and behold, he's got a Salter-Harris type 4 kind of fracture. It goes through the epiphyses, goes through the metaphyses across there. So sometimes, I mean, you have to kind of do everything, and then the buck stops at the MR, because MR has got the capability of delineating the bony injury much better than CT. Okay. Yeah, again, I mean, thinking about injury, patients present with a fall, unable to weight bear. His question is undisplaced hip fracture. X-rays are normal. CT is again kind of equivocal or inconclusive. Then you end up doing an MR. Obviously, on MR, you're looking for marrow edema in the neck, or like the case I showed you at the very start. But sometimes you don't find a marrow edema. All you find is muscle edema. And if you compare, this is the normal hamstring tendons there. This patient avulsed their hamstring tendon from the origin, and it will mimic like a hip fracture. Okay, so always think about muscle injuries or tendon injuries. And obviously, I mean, everybody, if you can pick it up, there is like this is what a pathological fracture looks like. I mean, you've got a focal lucency there with those kind of scalloped edging there. And then previous X-ray for a little great. I mean, you can see it was there. It should have been fixed there, but yeah, that's I mean, yeah, it happened, and then they fix it later on. So always think about pathological fracture. Right, talking about pathological fracture, I mean, the marrow infiltration, tumor, or infection. This was a rectal adenocarcinoma. Again, that was, yeah, okay. So yeah, this was a case, this is like the first case that I'm showing you. It's got like on bone scan, you can see widespread metastatic disease, no rectal adenocarcinoma. But this was another patient, or I think they were the same patient probably, and then it cut out. And then you can see there is, it was a different patient, beg your pardon. Again, you're seeing that there is this kind of scalloping there. There's this penumbra sign there. This was a secondary infection, which has led to that cut out. So infection can happen on the metalwork, as we know. I mean, you don't need to, I mean, I don't need to delve on this, but just to kind of get few points across. I mean, infection, hematogenous usually is the common cause, but if there has been any injection or instrumentation or like foreign body penetrating it can be direct inoculation as well. But we have got increasing number of patients now who are got comorbidities. They can have UTIs, or they can have acute cholecystitis, things like that. And then during that state, they can have hematogenous, they can have bacteremia, and bacteremia can cause septic arthritis, spondylolischitis, or in this young child, as you can see there is this iliacus abscess there from septic arthritis of the sacroiliac joint. So imaging infection again, I mean, we rely on everything there, but then sometimes you have to do radiotracer and hybrid imaging. And infection, I mean, I don't know. I mean, I think there is a pandemic of infection. I mean, we see it much more in this part of the world, probably in India and Pakistan and in the Asian continent as well, probably, because people don't get to hospital when they should, or they don't kind of think it's a thing which can cause a lot of complications. Like this patient, a young lady on a motorbike, had an ulceration there, came to ER, but then kind of left. Then a few months later, she presented with this. And then you can see on this, I mean, this has gone to the bone with that reactive new bone. It has gone across. This patient, if I tell you now, she's still got the limb, but she has lost one bone. They have to reconstruct the ulna with the radius, and she's a young lady. So infection can have a lot of comorbidity, a lot of morbidity for the patient. This one I'm just showing you again, soft tissue sign, again ulceration. There's this kind of lucency there. So X-rays again, we look for these things. I mean, whether it's an ectoplasmic fasciitis or if it's just an ulcer, depends. If there's an ulcer there, then obviously this is less of a worry. But in the absence of an ulcer, if you see gas in the soft tissues, that can be like Fournier's gangrene. It's quite a sinister sign. And they're looking for ulcer there. And this is what we call a ghost sign. Most of you might be aware of it. On MR, if you look at T1, everything looks kind of like one piece. But when you do STIR, you can have the outline of the bone. The bones appear. This is quite useful in the cases of infected Charcots. If it's just a non-infected Charcot, we usually tend to see the outline of the bone. I mean, bit irregular, but still you can define the bones on T1. But when you lose that definition on T1, which appears on STA, it's usually a sign of infected Charcot or osteomyelitis. Again, just the same cases. This was a case which I'm just sharing because this patient again was diabetic. There was some gas there. On CT, we found it, and we you can see there's gas in one side, but there's also gas in the sinus tarsi and subtalar joint on the other side. This patient had necrotizing fasciitis, and he had to undergo above knee or below knee amputations. So necrotizing fasciitis on MR, it's just a mess basically. I mean, usually we do CT to look for gas, but obviously if you do an MR, you can see a lot of like fasciitis, facial enhancement to muscular fluid, and sometimes areas in the muscle of like abscesses or lack of enhancement, which can tell that this probably is not viable. But it's a clinical diagnosis nevertheless. And whenever there's an MR for necrotizing fasciitis, I think it's very useful. It's important that whoever is reporting it, they contact the clinician to get that the clinical input, and then because that will save a lot of because if it's sometimes we have to raise it, right? Okay, we have to raise the possibility of it. But if the clinician is asking for it, then it's important to have a chat with them to see how strong the clinical suspicion is. Okay, so I mean again. On CT, I mean, we do CTs to look for septic focus. It's always a good idea to look at the shoulders, look at the hips, at the top slice and bottom slice to see, because sometimes you can have people with septic arthritis, and that will be the focus of infection, septicemia, more than anything in the abdomen or chest for that matter. That patient had to have excision arthroplasty and semen spacer. Right. One thing, I mean, this is an old paper, but I think there's an important point there, that if on a T1 weighted image, if we have got a very sharp delineation with the fatty marrow, it's usually tumor. And if it's a bit vague, it's a bit ill-defined, it's just kind of meddling in, or it's a bit ill-defined there, then it is osteomyelitis. So that's what it's saying, that on T1 weighted images in comparison to STIR is the most significant. A sharp, well-defined margin is the most significant feature of Ewing's in differentiating from osteomyelitis. So that's usually they're the young people. So in young people, if you've got this kind of a T1 weighted image, always think about tumor. Obviously, I mean, they can mimic each other. Both would need biopsy and culture. So that's what we say, biopsy, infection, and culture tumor, because on imaging, sometimes it can be difficult to differentiate one from the other. Ultrasound, I mean, I put this there just, I know, I mean, most of you will be doing ultrasound, but I just like to put it in there because sometimes this is the first portal of all, and that's for query collection, for query tear, things like that. But it's very important to, when you're scanning, use the right probe, right, and kind of scan from the skin to the surface of the bone. At least you have to have an idea which plane the abnormality is. Is it subdermal, subcutaneous, fascia, deep to the fascia, in the muscle, next to the bone, things like that. It's very important to have that kind of, that's what I tell my sonographers as well, that if you're scanning, you need to give me an image to tell me where that lesion is, because that will change the differential and the subsequent management. And with basic things, I mean, I'm just here to kind of give you some basic tips here. I mean, this is not a talk on MSK ultrasound, but for me, when it comes to MSK ultrasound, when I look for pathology, there are three things. One is, if it's a structure, I know how it looks like. Does it look the same? Is it the ecotexture has changed, particularly about the tendon? I mean, with tendon, I can't see fibrillar ecotexture, or it's a bit fuzzy, or it's really black and dark. Then I know this is not normal. So one is deranged ecotexture. The other is abnormal fluid, whether it's in the joint, in the bursa, or in a tendon, or in the area of the ligament, right? Things like that. And obviously, we use Doppler flow, which is a surrogate for contrast enhancement. So this is again showing you a patient who's got acute kind of like worsening Achilles, like dorsal heel pain. You can see that the Achilles tendon, you can see the normal kind of ecotexture there, but there is fluid in the retroclavicular bursa, and there is florid bursitis there. So this patient has got retroclavicular bursitis. Tendinopathy is the term we usually use. Obviously, this is the normal kind of ecotexture of the Achilles tendon. It can, when it's tendinopathic, it can become fusiform. You lose that ecotexture there. Similarly about the shoulder as well. So a normal texture is replaced by more like a fuzzy kind of texture with a bit of bursitis there. So, and then tendinitis is the term we use when the tendon has got intrinsic vascularity. That's the term we use rather than a tendinosis. Common extensive tendinitis with some calcification there, like a tennis elbow or a golfer's elbow in that matter. This is the common flexor lesion or patellar tendinitis. And tendon tear, I've shown you these images before, but obviously with Achilles, with calf tendon, even sometimes you can have quadriceps tendon tears. So ultrasound is quite useful. So what we're looking for is discontinuity of a structure with a fluid-filled flap. And then collections can have any kind of form. I mean, this looks like a hematoma or something, but even thick pus can look quite hyperechoic. And then you see these kind of reflective things, you always think about, could it be gas? Right? Okay, so I'm sure most of you will be much more well versed on these than myself, but these are just important precepts to keep in mind. Looking for collection, where it is it above the fascia, deep to fascia? And obviously, I mean, regions like the buttock or the back are quite tricky to scan, particularly in large patients. Whenever there is doubt, it's important to go to MR or to CT to see how deep the things go. Right? So talking about effusion, I mean, obviously, whenever you see a big effusion, you have to use Doppler, right? Okay. And I mean, when I see this is an acutely inflamed joint, right? Whether this is pus, I mean, you would say that with pus, you'll get more echogenicities or more like debris in it or layering, things like that. But in my experience, I mean, if it's there, it's okay. But when this is an inflamed joint, it needs an aspiration, right? Whether it's gout, whether it's rheumatoid, whether it's infection, I mean, I can't tell on imaging. So I think I'll take that fluid out and sample it. So this is acute synovitis. And then this again, young patient. And again, I mean, this is a different, you can see that there is anechoic fluid, but there is some hyperechogenicity as well. Okay? So this will make you think, could it be pus or could it be blood? This patient was hemophilic, so this was just hemophilic, just a hemarthrosis, atraumatic. We use the term tenosynovitis when you've got the tendons, you've got tendon sheath, like the biceps tendon sheath or the posterior tibial tendon, ECU. So whenever there's fluid along the tendon, particularly the tendons who've got tendon sheath, like flexor tendons on the fingers, we use the term tenosynovitis. Again, this can be, I mean, rheumatoid arthritis, could be psoriatic arthropathy, could be gout, could be infection in the case of fingers for that matter. So always, I mean, we have to, like we say, this is like chloride tenosynovitis, causes are myriad, but obviously if it's an infection, usually there will be ancillary features, patient will be unwell or there'll be some redness there or the CRP and ESR will be up. And sometimes they're tricky to kind of aspirate. Okay? But if you can aspirate, it's probably useful. Okay? Because if this is like this and the history is short, I think if they ask you to inject, then you need to be sure, you and the clinician should be sure that there is no kind of, no strong possibility of infection. But if in case of doubt, I mean, I won't inject them. They can treat it and then with anti-inflammatories or with antibiotics, whatever, because you don't want to end up causing harm. If you're not sure if you're the clinician and not sure that this can or cannot be infection, then I think don't put steroids in that episode. Again, just showing you a few more examples there. All right, okay. I put gout there. I mean, this was I just presented in one of the rheumatology meetings. The use of ultrasound is it's our, as a radiologist, as an MSK radiologist, it's an opportunity for us to talk to the patient, to take a history, and the patient will point out where the pain is. It's just our clinical input that counts. And if I show you these two X-rays, this patient has got midfoot pain, and you compare the right and the left side. If this is on your reporting file, probably you will say everything looks okay. There's nothing that strikes you, but when the patient comes, you do an ultrasound, the patient says, I've got pain here, and you go back and you look back, and then you see there is kind of active synovitis in the 4TMT joint, and you come back and you can see there's these kind of ledge-like erosions, right? Okay. That makes you suddenly think that this patient could have gout. Okay. So focused ultrasound helps us focus, basically. So it's always a good habit to have that skill in hand. If you do MSK ultrasound, always go back and look at the X-rays, and then you can make a difference. Okay, talking about crystal arthropathy, this case he was a prisoner presented with worsening pain like he was in wheelchair, can't stand, a limited range of movement, and the left knee, as you can see, on this X-ray APX, you can see there is lucency, focal lucency in the proximal tibia. But over here, there's a bit of scalloping there, and all that cloudy, lobulated kind of mass-like appearances around the knee, in the suprapatellar pouch, and there. Okay. So we did an ultrasound. We can't see much. I mean, there's a bit of hyperefficiency, but there is so much acoustic shadowing at the back that we can't make. But it doesn't look like fluid. And then you look at the foot, and lo and behold, the diagnosis is there. That is the typical erosion, juxtaarticular erosion with some osteolysis, probably intraosseous tophi, and this is soft tissue tophi as well. And then you do dual energy CT, and this patient has got very unusual presentation. Usually you see that in elderly men, but it can present in some young patients as well, with some like a genetic predisposition. So talking about I'm coming towards the end of my talk now. So that if the patient comes to ultrasound, what next to do, right? This is a patient who, you can see there is good going tricompartmental osteoarthritis with some erosions there. You do an ultrasound, worsening pain, but look at the fluid there. It's not clean fluid, right? So when I see this, I mean, with not much vascularity though, right? Okay. But the patient is saying the patient's CRP is up, she's got a UTI or things like that. And then this doesn't look right. I mean, the two things that I would be thinking about is it a hemarthrosis, the patient on anticoagulation, or is it pus? So it was aspirated and then that came as pus. Okay. So you can't tell. Sometimes you can't tell on ultrasound, but something doesn't look right. It doesn't look like a clean effusion, right? So again, I mean, that was Frank Paz, the patient. It was septic arthritis, and then the patient had a washout. Another one, I mean, again, doing an ultrasound for a patient with thigh pain, and then we saw this, like the egg-shaped kind of anechoic collection in the muscle. Again, looking from the skin, fat, then you got the rectus femoris. This is the femur, by the way. So it's just a juxtaosseous collection, deep collection there. Okay. You do an MR, and you can see there is a collection in the vasto intermedius muscle. And one thing, I don't know whether you guys use it or not, but I use it, or in our institution, we tend to use it. And if it restricts, it's usually useful. If it doesn't restrict, it doesn't mean much, though. But it restricts. There is definite kind of restriction of that fluid. So this is pus. Okay. This is acute pyomyositis of the vastus intermedius muscle that was drained. Probably a bit of early periostitis there, but not significant narrow edema to suggest acute osteomyelitis at that moment. Right. Last case there now. So again, similar presentation. So similar presentation I'm giving you. This is a 40-year-old present to ER with severe kind of pain, unable to weight bear. And then when I examined him, there was you can see that even on X-ray, there is some stranding, no history of injury though. But there is this stranding with loss of that fat muscle interface. And then one thing I would like you to kind of note that if you see here, there is obliteration of the Hoffa's fat pad. I mean, in the acute trauma setting, sometimes we see a bit of stranding and things like that, but whenever you see this obliteration, then you have to think that there is something going on. There is, so something is not right here, right? And when we do ultrasound, again, you got the patellar tendon there. There is some hypoechoic abnormality anterior to that. But when you come a bit lateral in the Hoffa's fat pad, you can see this hypoechoic thing. And then when you color, it has got vascularity. So there's a solid infiltrative process going on. I mean, is it TB? Is it tumor? So that was the thought. And then we did a CT. I mean, this is a CT that was done again. It shows you that infiltrative lesion. And again, on diffusion, it restricts. This is like a post-contrast scan there. And then this is T1, this is PD facet, this is post-contrast. You can see an infiltrative process that goes in the Hoffa's fat pad, but extends beyond the confines of the joint, goes into the muscle. But that restricted diffusion gives an important kind of information that this is a cellular process, right? Because usually sarcomas, they don't tend to restrict that much. Okay? So we made a differential that it's a cellular process. I mean, it doesn't look like pus. So could it be lymphoma or things like that? I mean, that was in the differential. Lo and behold, we did a biopsy, and they did a biopsy and came as T-cell lymphoma. So think about using diffusion for infection. Anything cellular will restrict. Okay. So coming to the end, I know it's a bit of a long kind of tapestry there, but that's how it is. So just So what I've tried to kind of show you all during the last hour or so is that whenever somebody presents with painful limb, the first three things are much more common, I think. We see them much more common. Like stress fractures in young recruits, they think they got a lateral meniscal tear, and you just see a bit of edema in the Hoffa's fat pad, like patellar mole tracking, or they can have a stress fracture. Infection, there'll be a history. Patient will be unwell, or the pain will be out of proportion. There will be ancillary features of the bloods. And infection can present weird and wonderful kind of thing. Okay. Infarction, if there's a history, or people who are ICU, who are acutely unwell with pancreatitis or in ICU, then you can have infarction affecting the marrow or the muscle for that matter. Like we see infarction in the like bowel ischemia. Similarly, think about ischemia or infarction in the musculoskeletal system. And then obviously infiltration. I mean, it can present in the acute setting as well, particularly with fracture. So that's about it, basically. I mean, anatomy, pathology, and us. And us means clinicians and radiologists. So that's about it from my side. This is Dr. Saifuddin. I'm sure most of you would have read his papers or his book. He passed away last year. I worked with him. I had the honor of working with him back in 2014 to 2016. So that's about it. Any questions, please fire away, or let's see. Yeah. Thank you.
Thank you so much, sir, for that amazing session. It was a really comprehensive review of acute acute abnormalities in MSK imaging, and a very well compiled sieve, I would say. There are a couple of questions, more than a couple actually. I'll just bunch them together and put across. Is that okay?
Yeah, please go ahead.
Yeah. So the most common question that's come up is about the penumbra sign. What is it, and in what all conditions do the T1 ghost sign or the penumbra sign appear?
Well, I mean, penumbra sign is that you have to have a T1 weighted image, and on T1 weighted image, if you see a hyperintense rim in the area of a collection, like on a fat suppressed fluid sensitive sequence, you see fluid, and then on the T1, like normal T1 fast plane echo without contrast, a plain T1, if you see a hyperintense rim to that, that means that this is an acutely inflamed kind of abscess with that hyperemia in because the capsule of the abscess, when it's forming, it has got blood, bit of iron and all that. So on T1 weighted, it appears bright. This is what I understand by penumbra sign. I think the neuroradiologists or the guys who report a lot of brain MR, they probably see them in cerebral abscesses as well. So this is what, in MSK, I found it very useful. I think particularly in people who are diabetic and you're not able, and they've got nephropathy and you're not kind of happy to give them contrast. So I use diffusion and penumbra sign to characterize the collections. So that's the penumbra sign.
Yeah, even we use it quite often, and it has a big help, especially when you're confused between inflammatory and infective joint effusions. Even tuberculosis abscesses, cold abscesses give that even hyperintense sign, as well as the osteomyelitis focus. So it is actually a boon when contrast cannot be administered. True, sir. The next is there a way to differentiate between PVNS and hemophilic arthropathy?
Yeah, yeah, the PVNS usually, if it's focal, it's easy, right? Like tenosynovial giant cell tumor, usually it's focal around like in the knee or in the ankle for that matter. When it's focal, it's easy. When it's diffuse, usually at the time of presentation, there'll be knee is the commonest joint that we encounter with tenosynovial giant cell tumor or PVNS. Okay, I'll use the term PVNS because we are just trying to move away from it. But PVNS, the commonest joint that we see is the knee, and usually there'll be a large effusion. There'll be hemosiderin deposition, but there won't be that degree of marrow edema or that destruction that you see with hemophilia. Because in hemophilia, first thing, I think the hemosiderin deposition is quite thick and irregular. Okay? But in hemophilic, by the time they present, because they've been repeatedly having these hemarthrosis and all that, and the hemosiderin is quite toxic to the cartilage, so they'll have a lot of bony changes. When in the absent, usually with PVNS, we don't see that degree of bony change. I think the bones are usually okay in my experience. But in hemophilic arthropathy, there'll be a lot of kind of osseous changes. So I think that's one way of differentiating it. But obviously, I mean, sometimes you can't, and then you have to end up doing a biopsy. Obviously, I mean, there'll be history as well. I mean, you can, I mean, if there's a history of hemophilia or any bleeding diathesis, then obviously hemophilic arthropathy will be your kind of first differential. But I think the key thing in my experience is with PVNS, usually there won't be any significant bony change. Okay.
True, sir. Yeah, thank you. The next is about ultrasound in synovitis. How reliable is Doppler to pick synovitis? And also on ultrasound, how can we differentiate between pyomyositis and a hematoma?
Yeah, I mean, ultrasound. I mean, we use. I mean, I think if you work in the European continent and in UK, we use ultrasound much more in rheumatology than if you go to the to US, because I think in US people use much more MR and MR with contrast for synovitis. I mean, it's a. I think it's. I can't quote a figure, but it's quite highly sensitive. I think, particularly in the small joints, and especially in the acute. If the patient has got acute symptoms or patient is symptomatic, then it's a good screening tool. Okay, and obviously when you're scanning for synovitis, you need to reduce your PRF to kind of like 0.8, less than 1, because you're looking for these micro vessels and obviously standoff and less pressure on the joints and things like that. Coming to the question for pyomyositis and hematoma, obviously with hematoma, I mean, we rely more on echogenicity. There'll be like layering of fluid. The clotted blood will be kind of dropping down. Like there'll be hyperechogenicities in the fluid. But I think hematomas are usually not as vascular as pyomyositis. Pyomyositis will be a collection, but there'll be a lot of increased vascularity around it. So pyomyositis will be much more angry than an acute hematoma. And again, with hematomas, one thing is important, that if you see a hematoma with a dodgy history, there's no history of trauma or anticoagulation, things like that, it's always prudent to call the patient back probably in like 3 to 4 weeks' time to see that it's resolving or liquefying, because unexplained hematomas in the soft tissues, particularly deep to the fascia, they can kind of mimic they can be the first transition of a sarcoma. So any hematoma unexplained, you always have to think, is there an underlying sarcoma? That's why it's important to follow them up. So if it's an angry looking kind of collection, a lot of vascularity, and especially both patient will have pain, but usually with pyomyositis, the pain will be much more, patient will be septic, and there will be a lot of vascularity around that collection.
Thank you, sir. The next question is how to diagnose insufficiency fractures on MRI?
Yeah, I mean, insufficiency fractures usually are like, I mean, we use that term in the context of like if there is no history of injury, or, I mean, usually what we like, we see lot of tibial kind of. I use the term insufficiency stress fractures synonymously, right? Because I mean, if insufficiency fractures, we use the term if somebody has got like underlying osteoporosis, osteomalacia, things like that. Okay? But I think the appearances on MR will be the same. The fracture line, if you can see a fracture line, well and good, but there'll be a lot of marrow edema there. The marrow edema will be disproportionate to the degree of the fracture line. The fracture line might be very subtle, okay, like I showed you on the. I'll put this image there for you. I mean, like this one. I mean, usually the marrow edema will be much more. If I go back, this one. So you see there, I mean, this is what we call about subchondral insufficiency fracture. SIFK, we used to use the term in the knee, right? But this, you can see it in the convex. I mean, the subchondral fractures usually they kind of occur in bones which are curved, like the femoral head, the talar kind of head, or navicular for that matter. You can see it just kind of conforms to the contour of the subchondral bone, but the marrow edema is much more extensive. I think that's when I see a fracture line which is small, but there's marrow edema much more to that, then I use the term insufficiency fracture or stress fracture. But sometimes you just see a bit of edema and then you don't see any fracture line. So there is a classification, I think it's called Fredrickson. I think Fredrickson probably, or I think that's the term.
Yeah. That's the tibial stress fractures.
Yeah, tibial or kind of lower limb fracture. So if you see like marrow edema without T1 signal, and then marrow edema with T1 signal with fracture, things like that. So there is all this kind of classification, which is useful you can resort to that. So I sometimes use that classification if I'm not sure. But the bottom line is, I think the marrow edema is much more than the fracture.
True, sir. The next is how to identify vertebral infarcts.
Okay. Yeah, I mean that's yeah. I mean you can. I mean again it's the context. I think if I mean the case I showed you, I mean it was like, because it's quite extensive, right? On that case, I just put this up there. I know. I mean sometimes it can be difficult, right? But you see, they're usually kind of large. If this is like a metastasis, by that time you'll get a bit of a fracture, or there might be some extra osseous kind of soft tissue extension, things like that. But I mean, sometimes it can be difficult. I think. I mean, I don't have an answer for that. I mean, I mean, if in the context of if this patient has got malignancy and you've got this, then obviously you'll say these are metastases. But in the context of a sickle cell, if you see this, then in that context, with previous history of infarcts and all that, I think you're reasonable to call them infarcts. The other thing is, I mean, follow-up is a great kind of helper. So in these cases, if we are not sure, you can follow up MR probably in a couple of months' time to see what's happening. So usually infarcts will show variable kind of resolution, and obviously metastasis will show probably progression if not treated. So I mean, it can be tricky. I don't have a right answer for that. It's just the morphology of it and in the context. Obviously, if this is the MR I'm reporting without a history, then I mean, I'll probably put infarct in the differential. But if there is, but metastasis will be my concern. But in the context, I know this patient got sickle cell disease. They got worsening kind of pain, and I've got a previous MR which there was nothing, or there were few areas, and now there are new areas. That kind of a thing. I mean, it's a judgment call. Again, that's where your rapport with the clinician kind of comes into play, and you have to discuss with him. And then, when not sure, then either you go for follow-up or go for biopsy. Yeah, because I mean, sometimes we don't have the answer, so we have to just play safe.
True, sir. The next is in the shoulder avascular necrosis case, can it be a neuropathic joint also?
Well, it can be, yeah. Neuropathic joints, obviously. I mean, in that case, if somebody got syringomelia or something like that, I mean, you can, I mean, neuropathic joints. But obviously, I mean, how often do we see neuropathic joints in the upper limb? It's quite rare. Again, in the context, if the patient has got kind of upper limb neuropathy or paralysis, then you can make a call for neuropathic as well.
Yeah, I think that like sums up the title of the talk and your introduction, which says a clinical radiologist is must.
Okay.
Yeah. I think that's the last couple of questions. Can we differentiate between a synovial cyst and a ganglion cyst on ultrasound? Aren't they the same?
Well, I mean, I don't know how different they are. I mean, and do we need to differentiate them?
True. Yeah.
I mean, that's the other thing as well. I mean, is it going to make any difference? I mean, I've never come across the term synovial cyst. I mean, we use it probably interchangeably. We use synovial cyst in the facet joints in the spine. Is it probably the same as ganglion cyst? I mean, they might be different, but only pathogenesis is different. But it doesn't matter, isn't it? It's a cystic lesion that you can establish a communication to a synovial structure, whether it's a tendon sheath or joint cavity, things like that. So I don't know. I mean, whether we can differentiate or. But my point is, do we need to?
I agree, sir. Does edema enhance on MR? Like, if it's there with around a lesion, sometimes it becomes difficult to differentiate where is the margin of the lesion and the edema is.
Yeah, I mean, well, edema can enhance because obviously, I mean, it's just leaky capillaries, right? Okay, so it's important to have. In my experience, I mean, when I started, I didn't used to have a pre-contrast T1 pad suppressed image, but now I tend to at least have one plain pre-contrast T1 pad suppressed, just to have that idea. And then you can do subtraction as well to see if there's any any enhancement. So, I mean, again, I think the key thing is you have to have a good quality plain T1 weighted image if you're dealing with tumor or infection to give the surgeon an idea where the tumor kind of ends to plan the resection margin. And I agree. I think when there's edema, I mean, it's tricky. I mean, edema is, in my opinion, I mean, if you're talking about malignant tumors like Ewing's or like osteosarcoma, if there is edema in the marrow, then I think it's I mean, if it enhances, then you can't tell whether there's any micro spread distal to the lesion. So I think it has to be taken in consideration when resecting the tumor. But most of the time, what happens is, I mean, these tumors, they usually get like neoadjuvant chemoradiotherapy, things like that, and then you can hope that if the tumor regresses, then again, I mean, it's case to case. You have to take it case to case. I mean, whether edema enhances or not, I mean, in my experience, I mean, most of the time it enhances. So, I mean, I give contrast in tumors to help kind of obviously, I mean, to help kind of see the extent of the tumor, but more importantly, to see which area is viable tumor, which I need to biopsy, which will give me the diagnosis. Whether there's any area of necrosis which I need to avoid kind of putting a needle in. I think that's much more important use of contrast rather than just seeing how far it goes. I think plain T1 is usually good. Some people use diffusion as well. I think there was a paper by Laura Fayed a few years back, probably 10 years back, that if you use diffusion, or the other thing is you can use in phase and out phase imaging, and then that can sometimes gives you a better tumor delineation. Because on stir or fat suppressed, obviously, the edema and tumor margins can mimic, can be confusing.
Yeah, just the last question, if you agree, can you show that plantar fasciitis case again and maybe just run through it once?
All right, okay. Right, let me go back to the first one. Just a second. Okay. And yeah, right. No, you mean this one or no, the plantar fasciitis one? Right. Okay. This one. Right. So this is. I mean, I'll go to the next slide as well. I mean, most of the time when we image these patients with plantar fasciitis, I mean, scan with the linear probe. Because with the hockey stick probe, usually the frequency is higher and the depth is not that great. So you have to have the depth. I mean, one can argue that I'm just wasted this space, but I think you can use it, but then it gets the picture becomes really bigger. So I usually tend to kind of image it this way. And this is the normal central band of the plantar fascia. Okay? When it gets plantar fasciitis, it can get swollen. It can become a bit more hypoechoic. Sometimes you can have some calcification in it. But then coming to the rupture case, I mean, I don't have the ultrasound for this, but I think if you look at this one, you can see this is the fascia. When I do ultrasound, I start from the midfoot. I find the deep fascia and then I track it back, dipping in, dipping down, going to the calcaneum. I think that's an important kind of way of avoiding the pitfall, because if you don't do that, then you can sometimes measure the muscle here. So if you start in here, you identify the fascia, then come back. You can see that it's a bit wavy, it's quite thickened, but over here, if you see, it's thickened and there is a discontinuity there. Okay? And then on MR, you can see the central band. This is the central band, okay? And there is this focal kind of defect there on this side. This is just thickened, but over here there is a discontinuity. So that's plantar fascial rupture. Ultrasound is useful, but I think it's important to do an MR. If you're suspecting a plantar fascial rupture, I think it's much better to get an MR, and then the surgeon can have a better idea what to do with it, because this is an unusual kind of pathology, and I mean it's a difficult condition. Sometimes, I mean, if most of the time the tear we see are interstitial, and on those, I mean, we tend to kind of treat them with PRP injections. But if it's a complete tear like this, then in young people, I think depending on which surgeon you work with, sometimes they can go in and repair it, or they can wait and let it scar. I mean, whatever. But the presentation, the patient will be in a lot of pain. Is that the case? Yeah.
Thank you so much, sir.
All right.
So that's all the questions.
Thank you for the interest and for your questions. Much appreciated.
Yeah, I'm happy to share there were more than 300 participants from 38 countries of the globe, and it was very well received. We have some really encouraging comments in the chat box, and that will surely invite you with a longer notice period for the next session, and we'll be happy to have you on this platform in future as well, sir.
My
Uh,
pleasure. Thank you.
and hope you have a great Sunday ahead.